This is Chapter 23, Toxicology. National EMS Education Standard Competencies. Medicine applies to the fundamental knowledge to provide basic and selected advanced emergency care and transportation based on assessment findings for an acutely ill patient. Toxicology is going to go over the recognition and management of carbon monoxide poisoning and nerve agent poisoning. You're going to learn how and when to contact a poison control center. AMP patho assessment and management of inhaled, ingested, injected, and absorbed poisons, alcohol intoxication and withdrawal, and opiate toxidrome. Advanced EMTs treat patients who have taken drugs of abuse on an almost daily basis. Due to the nature of drug use and abuse, it is almost impossible to identify the number of drug users. These may include legal or illicit drugs, such as alcohol and oxycodone. It may also include illegal or illicit drugs, such as heroin and ecstasy. A poison is a substance that is toxic by nature, no matter how it gets into the body or in what quantities. At minimum, it will make a person ill. At worst, it will kill a person. A drug is a substance that has some therapeutic effect when given in the appropriate circumstances and dose. Examples: reducing inflammation, fighting bacteria, or producing euphoria. Whether licit or illicit, when a drug is taken in excess, a person is said to have overdosed. Overdose is a toxicologic emergency. The person has been poisoned. Types of toxicologic emergencies. Toxicology is the study of toxic or poisonous substances. Toxicologic emergencies usually fall into one of two general headings. Those are intentional and unintentional. Intentional poisoning in adults is commonly intentional. Suicide is often accomplished with the use of drugs. Unintentional, which can occur in many ways, include medication dosing errors. It may be idiosyncratic. Childhood poisonings are common, especially in younger children. Nature is fraught with toxicologic perils. An example of this would be wild mushrooms. The workplace has toxic hazards. These are often not identified until exposure has occurred. Examples would be cancer from PCBs or asbestos. Unintentional toxicologic emergencies can occur as a result of neglect or oversight. For example, a person with diabetes takes too much insulin. Risks associated with chemical and biologic warfare have drawn increasing attention. Intentional poisoning or overdose may occur during more smaller scale crimes. Example would be flunitrazepam. That is the date rape drug used to facilitate sexual assault. Another example would be chloral hydrate, which is knockout drops used to commit assault. Pharmacologic agents are also used in homicides. Poison centers. It is difficult to keep up with the many street drugs. Don't hesitate to contact a poison center for fast information. The American Association of Poison Control Centers Poison Helpline is 1-800-222-1222. The people at the National Poison Control Center can give a fast rundown on the ingestion, its toxic properties, and steps to negate its effects. This will help you provide proper care. Poison control centers have access to information about all commonly used medications, chemicals, and substances that may be poisonous. Do not hesitate to use these resources when confronted with a toxin or poison you are unfamiliar with. Your call to the Poison Control Center also provides information to the center to help them understand trends, spot developing public health problems, and evaluate current treatment protocols for different poisonings. Some mobile medical reference apps, such as Hippocrates, will assist with pill identification. Poison Control also offers an online triage tool, a mobile device app called Web Poison Control that can be used by laypeople or healthcare providers. Pathophysiology routes of absorption. Toxins cannot exert their effects until they enter the human body. The four primary methods of entry are ingestion, inhalation, injection, and absorption. Each method of entry is unique, and so is the rate at which a given toxin is absorbed into the body. The combination of the amount of toxin and the relative speed at which it is metabolized determines its effects and excretion rate. Poisoning by ingestion. The most common sources are medications around the home and household chemicals such as cleaning agents. It may produce immediate damage to tissues or effects may be delayed for several hours. Ingestions of caustic substances cause damage immediately. Some poisons must be absorbed into the bloodstream before they produce toxic effects. Indicators. These may be obvious, such as a plant with partially chewed leaves or missing berries, stained fingers, lips, or tongue, or empty pill bottles from a recently filled prescription. A patient complaining of sudden onset of stomach cramps, with or without nausea, vomiting, or diarrhea, may have an ingestion-related problem. Toxins that enter the oral route generally take longer to be absorbed by the body, providing a more forgiving time frame for treatment. Little absorption occurs in the stomach. Substance may stay there for a variable period. Absorption occurs mostly in the small intestine. Most poison management aims to remove or neutralize poison before it gains access to the intestines. Syrup of ipecac is recommended only in a few situations in which the risk of losing consciousness is clearly low. Some emergency medical services systems may allow advanced EMTs to use activated charcoal as an alternative treatment. Activated charcoal comes as a suspension that binds to the poison in the stomach and carries it out of the system. It's more effective and safer than the syrup of ipecac. However, its administration carries the risk of severe pulmonary injury if aspirated. Assess the ABCs. Many patients have died as a result of problems with ABCs that might have been managed easily. Be prepared to provide aggressive ventilatory support and CPR to a patient who has ingested an opiate, sedative, or barbiturate. All of these cause depression of the central nervous system and slow the breathing rate. Whenever poisoning is involved, you should provide prompt transport to the emergency department. The patient may need IV support and/or other treatments that can only be given in the hospital. Poisoning by inhalation. Most common sources are home medications, household chemical products such as bleach or cleaning agents. Poison by inhalation can only occur if the poison is present in the surrounding atmosphere. As long as the patient is in the toxic environment, he or she will keep inhaling the poison, and so will you. Do not enter the hazardous environment. Call for resources with specialized protective equipment. In toxic environment situations, you are likely to encounter more than one patient at the emergency scene. Inhaled toxins quickly reach the alveoli. It provides almost instant access to the circulation. Rapid onset of signs and symptoms can occur. The window of opportunity for treatment is limited. When you are dealing with an inhalation emergency, the first general management consideration is scene safety. Specialty personnel will need to access the patient, and the patient may need to be decontaminated after removal from the toxic environment. The patient's clothing should be removed during this process because it may contain trapped gases that can be released, exposing you to the toxin. Inhaled toxins produce a wide range of signs and symptoms, many of which are unique to the toxin involved. It is helpful to take containers, bottles, and/or labels from the toxic substance with you when you transport the patient to the hospital. Often patients use inhaled poisons to commit suicide, such as when a person sits in a vehicle with the engine running in an enclosed garage. A recent variation on the use of automobiles for suicide, called chemical suicide, involves people using a tightly sealed vehicle as a type of gas chamber. Signs of chemical suicide include taped or sealed windows, locked doors, posted warning signs, a suicide note, empty chemical containers, unusual odor. If you suspect self-inflicted poisoning has taken place, contact hazardous materials responders and have them remove the patient. The emergency scene often contains clues about the identity of the toxin. Information from the scene and direction from the medical control physician will drive your treatment plan. You must treat hypoxia immediately, so administer a high concentration of oxygen. Establish vascular access and perform pulse oximetry. Call early for paramedic backup. Poisoning by injection is usually the result of drug abuse, for example, heroin or cocaine. Signs and symptoms can vary greatly. Frequently, the patient may be able to identify the source, greatly simplifying the assessment process. In general, injected poisons are impossible to dilute or remove. Injected poisons are quickly absorbed into the body or cause intense local tissue destruction. If you suspect rapid absorption has occurred, monitor the airway, provide high-flow oxygen, be alert for nausea and vomiting, remove jewelry from areas around the injection site if swelling occurs. Prompt transport is essential. Take all containers, bottles, and labels with the patient to the hospital. Bites and stings are considered poisoning by injection. Poisoning by absorption. Some poisons gain access to the body through the skin. Poisoning by organophosphates and pesticides are often the most serious. Many corrosive substances will damage the skin, mucous membranes, or eyes, causing chemical burns, telltale rashes, or lesions. Acids, alkalis, and some petroleum, such as hydrocarbon products, are very destructive. Other substances are absorbed into the bloodstream through the skin and have systemic effects. It is important to distinguish between contact burns and contact absorption. Signs and symptoms of absorbed poisoning include a history of exposure, liquid or powder on the patient's skin, burns, itching, irritation, skin discoloration, and odors typical of the substance. The first step is to avoid contaminating yourself or others. Remove irritating or corrosive substance from the patient as quickly as possible. Cut off all clothing that has been contaminated with poisons or irritating substances. Never pull clothing over a patient's head. Doing so could introduce the material into the eyes, nose, and mouth. You should never flush off a dry powder, as that could activate a chemical reaction. Dry off thoroughly first, then flush the skin with running water, and then wash the skin with soap and water. When a large amount of material has been spilled on the patient, flooding the affected part for at least 20 minutes may be the most effective treatment. If the patient has a chemical agent in the eyes, irrigate eyes quickly and thoroughly. To avoid contaminating the other eye, make sure the fluid runs from the bridge of the nose outward. Start the process on scene and continue throughout transport. Many chemical burns occur in industrial settings. Trained people will usually be there to assist you. Do not try to neutralize the substance with other chemicals. This may cause more harm. Instead, brush off as much as possible if the material is a solid, and then immediately wash off the substance with plenty of water. Obtain material safety data sheets, the MSDS, and transport them with the patient. The only time you should not irrigate the contact area with water is when a patient has been contaminated with a poison that reacts violently with water. Some substances ignite when they contact water. Brush the chemical off and apply a dry dressing to the burn area. Always provide prompt transport to the emergency department. En route, continue irrigation and provide oxygen if possible. Understanding and using toxidromes. There is a daunting number of substances of abuse. However, many result in similar signs and symptoms. For example, all narcotics, whether natural or synthetic, work in a similar manner. Toxidrome or toxic syndrome is a syndrome like symptoms of poisonous agent. It is useful for remembering the elements in assessing and managing different substances that fall under the same chemical umbrella. Major toxidromes are produced by stimulants, narcotics, sympathomimetics, sedatives and hypnotics, cholinergics, and anticholinergics. For a list of toxidromes, refer to Table 23.1 in your book. Table 23.2 lists common signs and symptoms of poisoning. By reviewing your history and physical exam findings in conjunction with vital signs, you can often develop a working diagnosis to provide appropriate pre-hospital care. Overview of substance abuse. And this is the area of medicine dealing with drugs of abuse, and it is highly challenging. There is uncertainty about the prevalence of the problem. Continual evolution of the substances occurs. Substance abuse is broadly defined as the self-administration of licit or illicit substances in a manner not in accord with approved medical or social practice. Society's definition may have little relation to the potential harm of a substance. Tobacco is not restricted but causes cardiovascular and respiratory disease. Marijuana use may result in fines or prison. Basic terms and concepts related to substance abuse. Drug abuse. Any use of drugs that causes physical, psychological, economic, legal, or social harm to the user or to others affected by the drug user's behavior. Habituation is a psychological dependence on a drug. Physical dependence is a physiologic state of adaptation to a drug, usually characterized by tolerance to the drug's effects and a withdrawal syndrome if the drug is stopped, especially if it is stopped abruptly. Psychological dependence is the emotional state of craving a drug to maintain a feeling of well-being. Tolerance is a physiologic adaptation to the effects of a drug such that increasingly larger doses of the drug are required to achieve the same effects. Withdrawal syndrome, a predictable set of signs and symptoms usually involving altered central nervous system activity that occurs after the abrupt cessation of a drug or after rapidly decreasing the usual dosage of a drug. Drug addiction, a chronic disorder characterized by the compulsive use of a substance resulting in physical, psychological, or social harm to the user who continues to use the substance despite the harm. Antagonist is something that counteracts the action of something else. In relation to drugs, a drug that is an antagonist has an affinity for a cell receptor. By binding to the receptor, the antagonist prevents the cell from responding. Potentiation is enhancement of the effect of one drug by another drug. Synergism, the action of two substances, such as drugs, in which the total effect is greater than the sum of the independent effects of the two substances. That is, 2 plus 2 equals 5. Drug abuse occurs in all age groups and social levels. Adolescents are particularly prone to experimentation. Your patient assessment. Generally, toxicologic emergencies are medical, but some may also lead to trauma. Your scene size up. For a toxicologic emergency, a well-trained dispatcher is of great value to determine important information that will help determine proper protection to ensure your safety. If this information is not obtained before your arrival, you must assess the scene thoroughly to ensure your own safety. Determine the nature of illness, mechanism of injury, the number of patients involved, a need for additional resources, whether spinal immobilization is required. Wear the appropriate personal protective equipment or PPE to avoid being contaminated. Patients who have taken an overdose may be extremely dangerous. Call for law enforcement backup if necessary. As you approach the scene, look for clues that might indicate a substance or poison involved. Are there medication bottles lying around the patient in the scene? If so, is there medication missing that might indicate an overdose? Are there alcoholic beverage containers present? Are there syringes or other drug paraphernalia on the scene? Is there an unpleasant or odd odor in the room? If so, is this scene safe? Is there a suspicious odor and/or drug paraphernalia present that may indicate the presence of a drug laboratory? Keep a constant, observant eye on the surroundings and keep an open mind when questioning patients and bystanders. Avoid coming to mistaken conclusions. Your primary survey. This begins with your general impression. Do not be fooled into thinking that a responsive, alert, and oriented patient is in stable condition. The patient may have a harmful or even lethal amount of poison in his or her system that has just not had enough time to produce a systemic reaction. Identify any life threats. Assess airway, breathing, circulation, disability, and exposure, your ABCDEs. Primary survey may also identify the mechanism of injury or nature of illness. A primary survey that reveals a patient with signs of distress or altered mental status gives you early confirmation that the poisonous substance is causing a systemic reaction. Quickly ensure that the patient has an open airway and adequate ventilation. Do not hesitate to begin oxygen therapy. Consider inserting an airway adjunct to ensure the airway remains open. Have suction available. You may have to assist the patient's ventilations with a bag mask device. Consider the potential for spinal injury. Spinal precautions in an unresponsive patient must begin when the airway is first opened and continued if positive pressure ventilations are needed. Use diagnostic tools such as a pulse oximeter. The reading may be inaccurate if the patient has been exposed to carbon monoxide. Always treat the patient and not the diagnostic tool. You'll hear us say that, treat your patient, not the monitor. Never withhold oxygen based on a pulse oximeter reading. Treatment for CO poisoning or carbon monoxide poisoning consists of high flow oxygen and transport to a hypobaric chamber. Assess the patient's circulatory status. Assess the pulse and skin condition. Stimulant exposure may result in restlessness, agitation, incessant talking, insomnia, anorexia, dilated pupils, tachycardia, tachypnea, hypertension or hypotension, paranoia, seizures, and/or cardiac arrest. Depressant exposure generally presents with respiratory depression, bradycardia, drowsiness, and possible coma. You will find variations depending on the substance involved. Check for bleeding. Obvious alterations in the ABCs or poor general impression are indications for immediate transport. A delay on the scene to further assess and treat patients is rarely indicated. Some industrial settings have decontamination stations and antidotes available on site. In these cases, decontamination and antidote administration will most likely have been initiated before your arrival and should not delay transport. Consider decontamination of the patient before transport depending on the poison the patient was exposed to. Decontamination is especially important when transporting in a helicopter. History taking. After completing the primary survey, begin obtaining the history. Many poisoning and overdose cases involve patients with medical conditions. In these cases, elaborate on the chief complaint using OPQRST. If your patient is responsive, begin with the evaluation of the exposure and the sample history, which can be done en route. If the patient is not responsive, attempt to obtain the history from other sources such as friends, family members, medical identification jewelry, cards, and wallets. Sample history. 3 assessments should give you direction in the interventions your patient may need. The sample history guides you into what to focus on as you continue to assess the patient's complaints. The physical exam helps to determine the visible signs of a reaction to the toxin, and vital signs may indicate any physiologic response to the exposure as well as give you an indication of the urgency. To choose the appropriate course of action in a toxicologic emergency, obtain at least the following specific information. What is the agent? If you know the substance involved, you will be better able to assess the appropriate resources and determine lethal doses, the time before harmful effects begin, and effects of the substance at toxic levels, also appropriate interventions. When was the poison ingested, injected, absorbed, or inhaled? This will let you know if and when the harmful effects will begin and how long ago harmful effects began. Affects treatments decisions for emergency physicians. Acute onset events often indicate a more serious patient scenario. You want to know how much was taken, injected, absorbed, or inhaled. The Poison Center will be able to inform you whether the patient has had a harmful or lethal dose. There is almost always a correlation between dose and toxic effects. What else was taken? A majority of intentional self-poisoning or illicit drug overdoses involve polydrug ingestions. This information will help the emergency department staff decide which tests to order. Over what period did the patient take the substance? Has the patient or a bystander performed any interventions? Has the intervention helped? Interventions performed before your arrival may cause more complications and affect future interventions. Has the patient vomited or aspirated? If so, how soon after exposure and how much? How much does the patient weigh? Antidote doses are usually based on the patient's weight. Why was the substance taken? You may not get a reliable answer, but it is important to ask. It could be an indicator of abuse or suicide attempt. Put the reason in quotation marks on your PCR. If the patient has overdosed on a prescription drug, take the pill bottle and the remaining pills to the emergency room with you. If the substance was a commercial product, take the container and its remaining contents to the emergency department. If the patient ingested a plant, find out what part and take a sample of the plant. If the patient vomits, save a sample of the vomitus in a clean, closed container. Secondary assessment. Focus on the area of the body involved with the poisoning or the route of exposure. The specific focus of your physical exam is largely based on the route of exposure and drug or chemical involved. Take the time to learn about the effects of general classes of drugs and chemicals. Once the life threats have been addressed and managed in the primary assessment, conducting a thorough physical will provide additional information on the exposure. A general review of all body systems may help to identify systemic problems. A complete set of baseline vital signs must be performed. Many poisons produce no outward indications of the seriousness of the exposure. Alterations in the level of consciousness, pulse, respirations, blood pressure, and skin are the more sensitive indicators that something serious is wrong. Keep in mind that carbon monoxide may produce false pulse oximetry readings. For your reassessment, the condition of patients exposed to poisons may change suddenly and without warning. Continually reassess the adequacy of the patient's ABCDEs. Repeat the assessment of vital signs and compare with the baseline set. Evaluate the effectiveness of interventions you have provided. Repeat the assessment of vital signs every 5 minutes or more often for a patient who has consumed a harmful or lethal dose, and every 15 minutes for a stable patient. Your interventions. Treatment depends on what the patient was exposed to, how he or she was exposed, and other signs and symptoms found in your assessment. Supporting the ABCs is your most important task. Dilute airborne exposures with oxygen. Remove contact exposures with copious amounts of water unless contraindicated. Consider activated charcoal for ingested poisons. These patients may vomit at any time, so continuously monitor the airway. Contact medical control or a poison center to discuss treatment options. Once you have completed your primary survey, history taking, and secondary assessment, contact medical control to request necessary interventions. Report as much information as you have about the poison or chemical to the hospital. If a safety data sheet is immediately available in a work setting, take it with you to the hospital. If this document is not immediately available, ask the company to send it via email or fax to the receiving hospital. Emergency medical care. Ensure scene safety, follow standard precautions, and perform external decontamination. Remove tablets or fragments from the patient's mouth. Wash or brush the poison from the patient's skin. Assess and maintain the patient's ABCs. Provide oxygen and perform assisted ventilations if necessary. If the patient demonstrates signs and symptoms of shock, provide treatment according to local protocol. If approved by medical control, give activated charcoal. Activated charcoal is not indicated for patients who have ingested an acid, an alkali, or a petroleum product, who have a decreased level of consciousness and cannot protect their airway, or who are unable to swallow. Activated charcoal adsorbs, not absorbs, adsorbs, or sticks to many commonly ingested poisons, preventing the toxin or poison from being absorbed into the body by stomach or intestines. You will likely carry plastic bottles of premixed suspension, each containing up to 50 grams of activated charcoal. Some common trade names are Instachar, Actidose, or Liquichar. The usual dose is 1 gram of activated charcoal per kilogram of body weight, which translates into 25 to 50 grams for adults and 12.5 to 25 grams for children. Administration of activated charcoal carries with it severe risk of aspiration. Never administer activated charcoal to anyone who is not alert or able to protect his or her own airway. Always check with medical control and/or poison control prior to administering. The major side effect of ingesting activated charcoal is black stools. If the patient has injected a poison that causes nausea, he or she may vomit after taking activated charcoal. The dose will have to be repeated. Be prepared for vomiting, nausea, and possible airway problems. Pathophysiology, assessment, and management of specific poisons. Alcohol is the most widely abused drug in the United States. 15 million people in the U.S., which more than 10% of the population, suffer from alcoholism. Alcoholism is a state of physical and psychological addiction. It is the fourth leading cause of death in the U.S. People with alcoholism tend to have chronic malnutrition and fall frequently, increasing the likelihood of trauma. It is a powerful CNS depressant. It is a sedative, which is a substance that decreases activity and excitement. It is also a hypnotic, which induces sleep. Alcohol dulls the sense of awareness, slows reflexes, and reduces reaction time. It also causes aggressive and inappropriate behavior and lack of coordination. A person who appears to be intoxicated may have other medical problems as well. Look for signs of head trauma, toxic reactions, or uncontrolled diabetes. Severe alcohol ingestion may cause hypoglycemia, which may contribute to symptoms. Assume that all intoxicated persons are experiencing a drug overdose and require a thorough examination by a physician. Severe alcohol intoxication is a form of poisoning. It carries the same lethal potential as other CNS depressants. Death from respiratory depression and/or aspiration of vomitus or stomach contents secondary to a suppressed gag reflex is the most immediate danger to an acutely intoxicated person. Physical dependence on alcohol results from the regular consumption of large quantities of alcohol. This becomes apparent when a person abruptly stops consuming alcohol and withdrawal symptoms result. The severity of the withdrawal can be varying according to the length and intensity of the alcohol habit. Minor withdrawal is characterized by restlessness, sleeping problems, agitation, and tremors. Major withdrawal symptoms include increased blood pressure, vomiting, and hallucinations. Delirium tremens, DTs, is alcohol withdrawal delirium. It results in tremors and restlessness, weakness, fever, diaphoresis, disorientation, hallucinations, confusion, hypotension, seizures, and possibly death. A person with alcoholism is considerably more prone than a sober person to a number of illnesses and injuries. Liver damage is the most common. Up to 90% of heavy drinkers have some level of hepatitis, and 10 to 20% of alcoholics will develop cirrhosis. Increased incidence of pancreatitis, development of erosive gastritis, increased risk of breast and colorectal cancer, and long-term abuse of alcohol leads to atrophy of the cerebrum, resulting in permanently reduced mental function. If an intoxicated patient is unresponsive, treat as you would any unresponsive patient. Establish and maintain the airway with an intact gag reflex. Place the patient in left lateral recumbent position with suction ready because the patient may vomit. If there is no gag reflex, place an appropriate airway and ventilate the patient with a bag mask device. Consider calling for paramedic backup for intubation and cardiac monitoring. Administer high concentration supplemental oxygen and assist with ventilation as needed. Establish vascular access. Assess the patient's blood glucose and treat hypoglycemia if it is found. Transport the patient to an appropriate facility. Internal bleeding should be suspected if the patient appears to be in shock, hypoperfusion, because blood might not clot effectively in a patient who has a prolonged history of alcohol abuse. A person who has been drinking heavily for an extended period and then stops suddenly may have a variety of withdrawal symptoms. Seizures usually occur within 12 to 48 hours. Use the same plan described for alcohol intoxication. Call for paramedic backup to give benzodiazepines for seizure control. Treatment for patient and DTs is aimed at protecting the patient from injury and supporting the cardiovascular system. Terrifying hallucinations can create combativeness in a patient. Try to keep the patient calm. Administer oxygen by nasal cannula. Establish vascular access. Manage hypotension with an infusion of normal saline and reassess breath sounds. Maintain dialogue with the patient to help orient and reassure the patient. Narcotics, opiates, and opioids. Narcotics are drugs that produce sleep or altered mental status, classified into two major divisions, opiate and opioid. Opiate is a natural drug derived from opium or poppy juice. Opioid is a non-opium derived synthetic. It is both illicit therapeutic agent and illicit substance. Narcotic abuse is one of the most common causes of overdose deaths reported to poison centers. Narcotic agents include morphine, codeine, heroin, fentanyl, oxycodone, meperidine, propoxyphene, and dextromethorphan. These drugs exhibit highly diverse effects and vary widely in potency. Opioids are used primarily in clinical medicine for analgesia. Heroin is abused for the unique euphoria it produces. Fentanyl and its derivatives are so potent that they can present a danger to you and other providers if you are exposed while caring for a patient. Opioids produce their major effects on the central nervous system by binding with receptor sites in the brain and other tissues. Opioids can readily absorb in the GI tract, but can also be absorbed from the nasal mucosa, such as snorting, or from the lungs by smoking. When taken orally, the effects of these drugs are lessened, compared with their effects when given parenterally. When heroin passes through the liver, it is metabolized into acetylmorphine, which continues to exert narcotic effects that may outlast the effects of naloxone, which is a narcotic antagonist. Morphine is a commonly used analgesic in the pre-hospital setting and is a potent vasodilator. When given to young adults, it is usually metabolized in 2 to 3 hours. It takes adults longer to metabolize morphine. Morphine and heroin produce an impressive dreamlike state. Shortly after injection, user will appear to pass out despite being quite lucid. Classic presentation of opioid use features euphoria, hypotension, respiratory depression, pinpoint pupils, vomiting may or may not be present, coma, seizures secondary to hypoxia, cardiac arrest secondary to respiratory arrest. Allergic phenomena may rarely occur with opioid use. With increased doses, coma, seizures, usually secondary to hypoxia, and cardiac arrest, usually secondary to respiratory arrest, are common. Naloxone, or Narcan, is an antidote that reverses the effects of opiate or opioid overdose. This medication can be administered via IV line, intramuscularly, or intranasally. The intranasal route is becoming a preferred alternative route for administering naloxone. The dosage of naloxone is 0.4 to 2 milligrams. Some EMS systems allow advanced EMTs to administer naloxone by the intranasal route. The antidote is atomized through the nares into the nasal mucosa. It may precipitate withdrawal symptoms resulting in violent behavior and/or seizure activity. Acute narcotic reversal may lead to vomiting and aspiration. This medication should only be used when the patient has agonal respirations or apnea. Place an oropharyngeal or nasopharyngeal airway and ventilate the patient using a bag mask device prior to administering naloxone. Provide adequate ventilation while administering naloxone to decrease the risk of permanent brain damage related to hypoxia. If the patient does not respond to naloxone, it is possible that the person has a mixed bag overdose. The patient may have taken multiple drugs, some of which are not opioids and will not respond to naloxone, or the person has a head injury. In such a scenario, insert an advanced airway, provide other care as needed, and transport the patient to an appropriate facility. It is important to remember that the patient may have other underlying illnesses, including hepatitis, HIV, AIDS, malnutrition, etc. Medications taken for any of these conditions may interact with the opioids, creating a myriad of symptoms. Older patients often take multiple medications for pain. For patients with chronic pain who take large doses of narcotics, dependency can become a problem. Monitor the patient closely and provide prompt transport to the closest appropriate facility. When completing your patient care report, be sure to document whether ingestion was intentional or accidental, how much was taken, and when it was taken. Document whether the patient has vomited since ingestion. Take any pills or bottles to the hospital with the patient. Report findings to receiving personnel and any illicit substances to law enforcement. Stimulants. Few drugs compare to stimulants in their abuse potential, particularly cocaine, amphetamines, methamphetamines. First-time users can become addicted within a few days. Once addicted, quitting is extremely difficult and highly unlikely. Stimulants may be taken orally, smoked, or via IV injection. Clinical presentation is excitement, delirium, tachycardia, hyper or hypotension with a fast pulse, dilated pupils. As toxic levels are reached, patients may experience psychosis, hyperpyrexia, tremors, seizures, and cardiac arrest. Cocaine is a naturally occurring alkaloid that is extracted from the erythroxylin cocoa plant leaves in South America. Once processed into cocaine hydrochloride, the active ingredient in the leaves is 100% pure, dramatically increasing its toxic potential. It is sold under many street names: Blow, Flake, Lady, Nose Candy, Snow, and Toot. It has had devastating effects on the U.S. population. Cocaine is a local anesthetic and a CNS stimulant. It also creates euphoria that features enhanced alertness, one of the most psychologically addictive drugs available today. Cocaine is quickly absorbed across all mucosal membranes. It can be applied topically, swallowed, snorted, or injected intravenously. It may be mixed with two inexpensive ingredients, baking soda and water. Once mixed together in a paste-like slurry and cooked or baked, the end result is smokable cocaine, or crack. When cocaine is snorted nasally, the effects are felt within 1 to 2 minutes and peak effects occur in 20 to 30 minutes. When cocaine is smoked, the onset of effects is much more rapid, 8 to 10 seconds, and the high is more intense, though the effects do not last as long. When the effects of cocaine wear off, the user experiences a crash characterized by depression, irritability, sleeplessness, and exhaustion. Depending on the amount and length of cocaine use, the person may experience a cascade of adverse effects, collectively referred to as cocaine washout syndrome. This syndrome presents as a hypoactive state related to a lack of synaptic neurotransmitters. To avoid the crash, the user will seek more cocaine or sedatives. Someone addicted to cocaine may also be addicted to other drugs. Amphetamines, structurally similar to derivatives of phenylethylamine, they include methamphetamine, known as ice or crank, methylene doxyamphetamine, which is MDA or Atom, and methylene doxymethamphetamine, which is MDMA, known as Eve or ecstasy. Amphetamine and amphetamine-like drugs have a number of legitimate clinical applications: nasal decongestants, diet pills, drugs for narcolepsy, drugs for attention deficit disorder, and attention deficit hyperactivity disorder. Methamphetamine is problematic because it is low cost, long acting, up to 12 hours, and extremely addictive. Ingredients to cook methamphetamine are available locally within the United States, and the drug is easily and quickly made. Its manufacturer avoids the hassle, risk, and high cost associated with importing cocaine. Meth labs should be treated as hazardous material incidents. Synthetic cathinones, marked and marketed as bath salts under unique names such as Blaze, have become a public health problem. These stimulants contain an active ingredient that is a pseudoephedrine, such as Sudafed, reduction drug called methcathinone, or a similar methamphetamine knockoff. Users typically snort, smoke, or ingest these drugs. These drugs couple the intensity and long-acting effects of methamphetamine with the euphoric effects of crack cocaine. The more serious side effects of these designer drugs include agitation, hallucinations, and paranoia. Signs and symptoms of stimulant abuse are wild-eyed, thin as a rail appearance, nervous or jittery movements. Week-long runs without sleep are not uncommon for serious users. Patients often go without eating as days pass, increasing paranoia sets in, and patients are usually amped up when you encounter them, and it often takes very little to set off a violent tirade. Cocaine may cause a variety of serious and potentially fatal complications, lethal electrocardiograph arrhythmias, acute myocardial infarction, seizures, stroke, apnea, hyperthermia. Crack smokers may risk pneumothorax and pneumomediastinum. Clinical presentation for patients abusing methamphetamines or amphetamines is almost identical to a patient abusing cocaine, except that the effects last hours longer. Use of synthetic cathinones is associated with significant paranoia, hallucinations, incredible strength, excited delirium, and other bizarre behaviors. Tachycardia, diaphoresis, nausea, and hyperthermia may also be present. Treatment for stimulants: maintain maximum oxygen saturation levels, prevent seizures with adequate sedation, monitor serial vital signs, consider paramedic backup for an advanced airway as needed, establish IV access, manage hypotension with a fluid infusion of normal saline, apply the pulse ox, call for paramedic backup to control anxiety and seizures, administer benzos per local protocol. If the patient has a seizure, protect the airway. Transport the patient to the appropriate facility. In severe cases of stimulant overdose, the patient may present with hyperthermia, which can be lethal. Application of ice packs or misting the patient's skin may reduce his or her temperature. Throughout the resuscitation process, it is essential to maintain peripheral perfusion with aggressive fluid therapy. Regular assessment of breath sounds to avoid inadvertent overhydration is necessary. Remember the potential for the patient to be emotionally or psychologically unstable. With chronic abuse, each passing day of no sleep and little or no food may make the patient increasingly paranoid and even psychotic. The behavior of a patient can suddenly become violent, so consider the situation a potential hazard. Contact law enforcement for support when you first suspect the possibility that violence may occur. Marijuana and cannabis compounds. They are harvested and dried leaves and flower buds of the cannabis sativa plant, also known as weed, pot, dope, or smoke. It is usually smoked but can be ingested, such as when baked in cookies. The onset of effects is minutes when smoking. Oral ingestion slows the onset time to several hours. Users have a distorted sense of time and space and occasionally a feeling of unreality. Smoking marijuana results in bronchodilation and slight tachycardia. Other signs and symptoms include euphoria, drowsiness, decreased short-term memory, diminished motor coordination, increased appetite, bloodshot eyes. Management focuses on supportive care. There's a low likelihood of serious medical complication. A novice user may exhibit some behavioral symptoms such as paranoia and rarely psychosis. Reassurance is helpful with both paranoia or psychosis. Spice is a mixture of dried plant material that is sold as incense in efforts to avoid existing drug laws. It is a psychoactive drug, is a blend of synthetic cannabinoids and knockoffs of the naturally occurring psychoactive elements in marijuana. The active substance is sprayed onto a plant-like material for smoking or sold as a liquid for vaporizing in e-cigarettes. Adverse effects include psychosis, hallucinations, tachycardia, vomiting, renal problems, and seizures. Obtaining a good assessment and forming a treatment plan for someone who has used spice can be challenging. Supportive care with fluids and airway maintenance is often appropriate. Benzodiazepines are the recommended medication for patients experiencing a seizure. Hallucinogens, they alter a person's sensory perception, seeing, hearing, or feeling things that aren't actually present. Experiences involving hallucinogens vary markedly, even among people taking the same dose of the same drug from the same batch. The classic hallucinogen is lysergic acid diethylamide, which is LSD. LSD primarily affects the senses rather than changing physiologic functions. Synesthesias is crossing of the senses, and that can occur with the use of this drug. With higher doses, the effects of LSD can last as long as 12 hours, although 3 to 4 hours is more typical. Effects of LSD are tachycardia, mild hypertension, dilated pupils. A bad trip can be frightening and cause acute anxiety attacks. Psilocybin mushrooms are probably not, uh, are the most frequently used hallucinogens in the United States after LSD. The onset of symptoms and hallucinogenic effects, similar to LSD but less intense, is within 30 minutes of ingestion, and effects usually last 4 to 6 hours. Signs and symptoms include nausea and vomiting, uh, mydriasis, mild tachycardia, and mild hypertension. The likelihood of any serious medical side effect is low, though seizures and hypothermia may occur. Phencyclidine, or PCP, also known as angel dust, relatively uncommon among young adults. PCP is typically smoked or snorted, though it can be injected. Slurred speech, staggering gait, tachycardia, hypertension, staring blankly for extended periods, and horizontal nystagmus, which is involuntary rhythmic movements of the eyes. are common with PCP use. Muscle rigidity and especially grinding of the teeth prompt many users to resort to pacifiers in an effort to avoid pronounced jaw aches. The hallmarks of PCP use include mind and body separation, related hallucinations, and violent outbreaks. Users have a high tolerance for pain and can also exhibit superhuman strength. Ketamine, which is known as Special K or vitamin K, it is similar in chemical structure to PCP. Most ketamine available on the street is stolen from veterinary clinics, although this drug is increasingly being used in emergency medicine. Ketamine is a popular club drug. It is frequently used in combination with other club drugs, alcohol, and stimulants. Ketamine is colorless and odorless and is commonly found in powdered form. It is often mixed in a drink, although it can be snorted. It is a dissociative anesthetic. Users present with mild inebriation, dreamy or erotic thoughts, and increased sociability. At higher doses, a patient may have pronounced nausea, difficulty moving, and a complaint of entering another reality. In extreme cases, users will enter the K-hole, which involves out-of-body experiences. Long-term use can result in extensive problems with memory, cognitive impairment, and/or an inability to properly speak or see. Mescaline is dried flower buttons of the peyote cactus. It is a hallucinogen. No currently accepted medical use in the United States. Profound vomiting occurs shortly after its ingestion. The psychedelic experience then typically begins with feelings of increased sensitivity to sensory stimulation. Users may experience hallucinations, a distortion of time and space, or out-of-body experiences. The physical effects of mescaline are similar to LSD, including dilated pupils, increased heart rate, mild hypertension, and increased body temperature. Treatment for a patient using hallucinations is primarily supportive. Try to limit sensory stimulation as much as possible, for example, by avoiding the use of emergency lights and sirens. Routine transport to the appropriate facility plus psychological support is usually all that's required in the pre-hospital setting. For patients who have used PCP or ketamine, secure the patient well, assess the ABCDEs, and manage any life threats. Administer oxygen therapy and establish vascular access if the patient is receptive. Provide safe transport to the appropriate facility. Benzodiazepines may help calm an agitated patient who is experiencing significant delirium. PCP can cause violent and difficult behavior. Protect the patient and the EMS team from attacks involving poor judgment and impaired behavior. Care for mescaline users and psilocybin mushroom users is primarily supportive. Pay attention to the ABCDEs, give oxygen therapy, monitor vital signs, provide positive psychological support, and provide safe transport. If time and circumstances allow, establish IV access to provide a medication route. Sedatives and hypnotics. Sedative hypnotic drugs have a wide range of applications. Sedatives reduce anxiety and calm agitated patients. Hypnotics help produce drowsiness and sleep. They function primarily as CNS depressants. Barbiturates have a long history of use as sleep aids, anti-anxiety drugs, and seizure control medications. Combination of alcohol and barbiturates used frequently by people to attempt suicide. Suicide attempts and accidental overdoses have led researchers to develop sedative hypnotics that are less lethal and have fewer depressive effects on the respiratory system. With mild to moderate barbiturate intoxication, patients present similar to those with alcohol intoxication. Symptoms are drowsiness, decreased inhibitions, ataxia, mental confusion, and staggering gait. As the dose increases, patients become increasingly lethargic and demonstrate an increasingly lower level of responsiveness until they are unresponsive. Barbiturate users quickly develop tolerance and require ever larger doses to produce the desired effects. Long-term use results in physical addiction. Abrupt cessation in a long-term abuser will produce typical signs and symptoms of withdrawal syndrome. In the case of minor withdrawal, symptoms are similar symptoms of alcohol withdrawal: restlessness, uh, tremulousness, insomnia, diaphoresis, abdominal cramping, and nausea and vomiting. Patients in severe withdrawal may present with delirium, hallucinations, psychosis, hyperthermia, and cardiovascular collapse. Benzodiazepines. They are members of the sedative hypnotic family, commonly used to treat anxiety, seizures, and alcohol withdrawal. Effects include sedation, reduced anxiety, and relaxation of striated muscle. Assessment can be complicated because the person is also likely to use other drugs and alcohol. The most common clinical effects of overdose include altered mentation, drowsiness, confusion, slurred speech, ataxia, and general lack of coordination. Withdrawal from benzodiazepines may include tachycardia, tremulousness, confusion, and possibly seizures. Withdrawal is rarely a life-threatening event. Care. Airway management is first priority. Call for paramedic backup to intubate and monitor the ECG rhythm. Administer high concentration oxygen and establish IV access. If shock develops, rapid infusion of 1 to 2 liter boluses of normal saline may be needed. Assess breath sounds before and after each bolus rather than infusing an entire liter and then assessing breath sounds. Romazicon or flumazenil is a reversal agent, is available for managing a benzodiazepine overdose, although its use in the pre-hospital setting is rarely warranted. Activated charcoal is an option for treatment of patients after 60 minutes have passed. Do not administer it to patients who are at risk of becoming unresponsive or of losing the ability to protect their airways. Vomiting can occur, and aspiration of activated charcoal can be exceedingly dangerous. Cardiac medications. Um, these are medications used to treat cardiac and cardiac-related problems. They continue to increase in number and sophistication. Major classes are antidysrhythmics, beta blockers, calcium channel blockers, cardiac glycosides, and angiotensin-converting enzyme inhibitors. Many patients take a combination, sometimes as many as 3 or more. Overdose on these medications is usually accidental. Signs and symptoms of overdose with cardiac drugs vary but may include hypotension, weakness or confusion, nausea and vomiting, heart rhythm disturbances, most commonly bradycardia or a heart block, headache, and difficulty breathing. Ensure a patent airway, provide adequate ventilation, administer high-flow supplemental oxygen, establish IV access. Interventions and antidotes are available if the specific agent is identified. In case of hypotension, sequential fluid boluses of normal saline will often bring the blood pressure into an acceptable range. Because of the sophistication of cardiac drugs and the likelihood that the patient may be taking multiple medications, contacting medical control to consult with a physician is prudent. Other medications. Erectile dysfunction medications are the most dangerous of the various drugs that increase sexual gratification. These drugs, such as sildenafil, which is Viagra, tadalafil, which is Cialis, or vardenafil, which is Levitra, are contraindicated for patients who take nitrates for cardiac conditions. In these patients, erectile dysfunction medications may result in severe hypotension or total cardiovascular collapse, ultimately leading to death. If patients develop hypotension, then repeated boluses of normal saline can increase the blood pressure to an acceptable level. If cardiac arrest occurs, follow your protocols. Patients taking a variety of psychiatric medication may experience toxicological emergencies. Tricyclic antidepressants, or TCAs, carry a high risk of intentional overdose. Common signs and symptoms of a TCA overdose are altered mental status, drowsy, confused, slurred speech, dysrhythmias, sinus tachycardia, or supraventricular tachycardia, dry mouth, blurred vision or dilated pupils, urinary retention, constipation, pulmonary edema with more serious toxic exposure. Be alert for ventricular tachycardia, hypotension, respiratory depression, and seizures. Remember that dysrhythmias may be life-threatening. Managing patients with a TCA overdose includes the following measures. Maintain the airway if the patient's mental status suddenly deteriorates. Insert an advanced airway. Call for paramedic backup as needed for cardiac monitoring, intubation, and medication administration. Administer high-flow supplemental oxygen. Establish IV access. Administer activated charcoal per medical control orders. Manage hypotension with sequential boluses of normal saline. Be alert to the possibility of pulmonary edema. Assess blood glucose levels. Administer D50 in water if the patient is hypoglycemic. Rule out head trauma as a possible cause of the decreased mental status, and monitor for agitation or violence. Provide rapid transport to the closest appropriate facility. Monoamine oxidase inhibitors, which is MAOIs, sometimes used to treat depression but have a high potential for drug interactions. They can precipitate a hypertensive crisis if taken in conjunction with tyramine-containing foods. Symptoms are often delayed, occurring 6 to 12 hours after ingestion, and in some cases as long as 24 hours later. Early signs and symptoms include hyperactivity, dysrhythmias, usually sinus tachycardia, hyperventilation, and nystagmus. With increased levels of toxicity, be alert for chest pain, palpitations, hypertension, diaphoresis, agitated or combative behavior, marked hyperthermia, and hallucinations. The care for this, there's no antidote available. Establish and maintain the airway, administer high-flow supplemental oxygen, or provide positive pressure ventilation if needed. Establish vascular access. Consider administration of activated charcoal if recommended by medical control. Do not give syrup of ipecac. With a patient in deteriorating condition, treat hypotension with sequential fluid boluses of normal saline. If seizures occur, call for paramedic backup for medication administration. Selective serotonin reuptake inhibitors, or SSRIs, widely used medications for managing depression. Patients may be asymptomatic. Symptoms include nausea, vomiting, dysrhythmias, usually sinus tachycardia, sedation, tremors, and possibly dilated pupils, agitation, blood pressure changes, hypo or hypertension, seizures, and hallucinations. Managing a patient with an SSRI overdose follows the general approach for poisoned patients. Establish and maintain the airway, administer high-flow supplemental O2, establish IV access, call for paramedic backup as needed, consider a single dose of activated charcoal per medical control, and transport the patient to the appropriate facility. Lithium. This is the cornerstone drug for treating a bipolar disorder. It is excreted from the body slowly, hence the threat of toxic levels and overdosing is always present. Signs and symptoms include nausea, vomiting, hand tremors, excessive thirst, and slurred speech. At increased toxicity, patients may develop ataxia, muscle weakness, and incoordination, blurred vision, and hyperreflexia. Eventually, patients may have seizures and become comatose. Managing a patient with a suspected lithium overdose is mostly supportive. Establish and maintain the airway, inserting an advanced airway as needed. Administer high-flow supplemental oxygen and ensure vascular access. If the patient experiences hypotension, administer serial boluses of normal saline and transport the patient to an appropriate facility. Non-steroidal anti-inflammatory drugs, known as NSAIDs, are some of the most popular options for pain relief, fever control, and anti-inflammatory action. Most of the problems associated with NSAIDs involve long-term use. Patients may experience gastrointestinal bleeding and kidney dysfunction with chronic use. Signs and symptoms include headache, altered mentation, behavioral changes, seizures, bradydysrhythmias, hypotension, abdominal pain, nausea, and vomiting. Care in the pre-hospital setting is usually supportive. Establish and maintain the airway, inserting an advanced airway as needed. Administer high-flow supplemental O2, establish IV access. If hypotension develops, administer fluid boluses of normal saline. If hypotension persists after sequential fluid boluses, consider calling for paramedic backup for medication administration. Transport the patient to an appropriate facility. Salicylates. Over-the-counter products containing salicylates cause toxicity. With continued use of these products over a period of days, infants or young toddlers may ingest toxic levels of the salicylate. Chief complaints are nausea, vomiting, abdominal pain, diaphoresis, hyperpnea, ringing in the ears, pulmonary edema, acid-base disturbances, metabolic acidosis or combined respiratory alkalosis, metabolic acidosis in cases of severe toxicity. No salicylate antidote or antagonist is available. Field management is primarily supportive. Establish and maintain the airway, inserting an advanced airway as needed. Administer high-flow supplemental oxygen and establish IV access. If hypotension develops, administer serial boluses of normal saline. Monitor carbon dioxide levels with capnometry. Administer 1 dose of activated charcoal after consultation with medical control. Call for paramedic backup as needed and transport the patient to the closest, most appropriate facility. Acetaminophen is a well-tolerated drug with few side effects that is available over the counter. It is important to try to accurately estimate the time of its ingestion. This information derives the decision-making process for patient care. An antidote for acetaminophen toxicity exists, which should be given less than 8 hours after the ingestion. Pre-hospital management is establish and maintain the airway, establish vascular access, consider administration of activated charcoal after consulting with medical control, and transport the patient to an appropriate facility. Gamma hydroxybutyrate, or GHB, is frequently associated with sexual assaults. It is available as an odorless and colorless liquid. It has a salty taste, but this may not be noted when placed in a drink. It produces a pronounced hypnotic effect along with disinhibition, severe passivity, and antegrade amnesia. Treatment focuses on the CNS depression and the risk associated with the patient being unable to protect the airway. Establish and maintain the airway, insert an advanced airway as needed, carefully monitor the patient's level of consciousness, assist breathing as necessary, and administer high-flow supplemental oxygen, establish vascular access, apply the pulse oximeter, and provide rapid transport to the ED. Organophosphates. These are a major component in many insecticides, orthene, diazinon, and malathion. They are used in agriculture and in the home. Similar performing compounds are used as nerve gases designed for chemical warfare. Organophosphates and nerve gases are classified as cholinergic agents. These agents overstimulate normal body functions that are controlled by the parasympathetic nerves. They result in salivation, mucus secretion, urination, crying, and an abnormal heart rate. You are unlikely to encounter nerve gases. You may be called to care for patients who have been exposed to organophosphate insecticides or pesticides or certain wild mushrooms. Suicide attempts account for a considerable share of organophosphate poisonings. When suicide is the goal, the poison is usually taken by mouth. Accidental agricultural exposure is another common source. Persons involved in the manufacturing of organophosphates and similar compounds are at risk. The symptoms of organophosphate poisoning are fundamentally the same regardless of route of entry: anxiety and restlessness, headache, dizziness and confusion, tremors or seizures, dyspnea, diffuse wheezing, respiratory depression, and loss of consciousness. A patient poisoned with organophosphates will usually present with signs and symptoms within the first 8 hours. CNS signs and symptoms associated with cholinergic excess are often expressed. The sludge M mnemonic is helpful in assessment: salivation, sweating, lacrimation, which is excessive tearing of the eyes, urination, defecation, and emesis, muscle twitching or meiosis, pinpoint pupils. Alternatively, you can use the mnemonic dumbbells, um, diarrhea, urination, meiosis, which is constriction of the pupils, muscle weakness, bradycardia, bronchospasm, bronchorrhea, which is discharged mucus from the lungs, and emesis, lacrimation, seizures, salivation, and sweating. Assessment and management starts with decontamination and removal of all contaminated clothing before initiating care or loading the patient into the ambulance. Contaminated clothing should be placed in plastic bags and disposed of as hazardous materials. Ideally, the patient should be scrubbed with soap and water. After that, patient care includes the following measures: establish and maintain the airway, consider an advanced airway is needed, suction is needed, give high flow supplemental oxygen, establish vascular access, call for paramedic backup for medication administration and cardiac monitoring, apply the pulse oximeter, transport immediately to the closest appropriate facility. The military has developed antidotes to nerve gas agents that can be administered if they are available and indicated. The most common of these antidotes are the duodope kit, the antidote treatment nerve agent auto-injector or the ATNAA, and the Mark I kit. The indications for these antidotes are a non-exposure to nerve agents or organophosphates with manifestations of signs and symptoms. Removal of the patient from the source of the exposure is also critical in these cases. If your service carries these antidote kits, you should receive training on their proper use prior to being cleared to administer them. Carbon monoxide, known as CO, is one of the most common fatal poisonings. Carbon monoxide is produced during the incomplete combustion of organic fuels, such as in an automobile engine or a home heating device. Poisoning may occur when a flue or ventilating system becomes blocked. It may also be a method of suicide. An automobile running in a closed garage is a major contributor to death and house fires. It is colorless, odorless, tasteless gas. People exposed have no idea until it's too late. The toxicity arises primarily from the affinity of CO for hemoglobin in the red blood cells. Carbon monoxide displaces oxygen, thereby preventing the red blood cells from carrying oxygen to the tissues and leading to suffocation at the cellular level. The atmospheric level of carbon monoxide does not need to be very high for poisoning to occur. Anything that increases the body's oxygen requirements, such as physical exertion or fever, will increase the severity of the poisoning. Children tend to have more severe symptoms at any given level of exposure due to their high metabolic rate. Carbon monoxide poisoning can be difficult to diagnose in the field unless it is the direct result of an easily identifiable cause, such as a fire. Signs and symptoms are variable and vague, often resembling early onset of the flu. Examples are headache, nausea, and vomiting. With acute carbon monoxide poisoning, the patient may be confused and unable to think clearly. Complaints of a sensation of pressure in the head or roaring in the ears are common. Physical exam often reveals bounding pulses, dilated pupils, and pallor or cyanosis. Consider the possibility of carbon monoxide poisoning whenever you are confronted with several, possibly many patients with these symptoms who have shared the same accommodations for any period, especially if they have been quartered together in a closed area, such as in one house in the winter. The cherry red color of the skin mentioned in many textbooks is a very late sign. Recent developments in technology have given advanced EMTs the ability to perform non-invasive identification of carbon monoxide poisoning, and this is carbon monoxide saturation of the blood in the field. Pulse oximetry will not provide a true assessment of arterial oxygenation because the device cannot determine whether carbon monoxide or oxygen is bound to the hemoglobin. Carbon monoxide monitoring devices use the same probe that is used to measure oxygen saturation, but measures the carbon monoxide saturation. If your service carries a CO monitoring device, ensure that you are familiar with how to use it. Treatment of CO poisoning in the field is aimed at providing the highest concentration of oxygen possible to attempt to displace CO molecules from the hemoglobin. For patients with only mild symptoms, the elimination half-time of carboxyhemoglobin is roughly 4 hours. By comparison, if the patient is breathing 100% oxygen, the half-time can be reduced to about 1.5 hours. Hyperbaric oxygen therapy can further reduce the elimination time. If you suspect carbon monoxide poisoning, remove the patient from the exposure environment. Establish and maintain the airway. Inserting an advanced airway is needed. Give high-flow supplemental oxygen by a tight-fitting, non-rebreathing mask. Establish vascular access. Keep the patient quiet and at rest to minimize oxygen demand. Monitor the LOC. Transport to an appropriate facility. If the patient is unresponsive or has signs of serious CO poisoning, direct transport to a facility capable of providing hyperbaric medicine is preferred. For patients with injuries or illness from a structural or vehicular fire, consider the possibility of combined carbon monoxide and cyanide exposure, especially if the patient has signs of shock. Metals, lead. Its elevated levels of lead exposure may significantly hamper intellectual development in children. With inorganic lead, absorption usually occurs via the respiratory or GI tract. Once inside the body, approximately 90% of the lead is stored in the teeth and bones. From this side, it eventually makes its way into the bloodstream. Inorganic lead can also cross the placental barrier and negatively affect fetal development. Its excretion from the body is incredibly slow, with the half-life of lead in bone estimated at 30 years. Most organic lead or tetraethyl lead exposures occur in occupational settings, although they can also occur from gas sniffing where leaded gasoline is available. Once inside the body, tetraethyl lead is metabolized to inorganic lead and triethyl lead, with triethyl lead being the primary cause of CNS toxicity. Table 23.4 lists the signs and symptoms of lead poisoning. In particular, encephalopathy is a major cause of mortality and morbidity from lead poisoning. In the field, you have few treatment options for lead poisoning. Identify the source of the lead. This can assist the appropriate government agency to prevent more occurrences by removing the toxin. First, establish and maintain the airway. Inserting an advanced airway is needed. Administer high-flow supplemental oxygen. Establish IV access with a saline or heparin lock. Do not provide fluid therapy unless hypotension is present. Transport the patient to an appropriate facility. Iron. Although only a small amount of iron is required as part of a healthy diet, many adult and pediatric multivitamins contain iron. In the average 154-pound or 70-kilogram adult, the body's entire iron supply consists of only about 4 grams. Of that total, roughly 65% is found in hemoglobin, with the remainder sequestered elsewhere. Because of its toxic potential, iron is stored in the body by several mechanisms, which permit access to the supplies needed. The body of a healthy person does not contain free or unbound iron. The toxic effects of an iron exposure reflect the amount of elemental iron ingested. Expect mild to moderate toxicity if a patient ingests 20 to 60 milligrams per kilogram. With dosing of more than 60 milligrams per kilogram, severe and potentially lethal toxicity is a possibility. Two broad categories of iron poisoning can be distinguished: gastrointestinal and systemic. With gastrointestinal toxicity, the symptoms consist of abdominal pain, vomiting, which is the most common sign, and diarrhea. With systemic toxicity, patients may be hypotensive or in frank shock from coagulopathy and vomiting blood. These patients are commonly in metabolic acidosis, become tachypneic as the body attempts to adjust its pH by increasing the elimination of carbon dioxide. Children typically remain asymptomatic when they have been involved in a low-level iron exposure. Children who ingest a large dose of iron are at risk of dying unless aggressive and immediate interventions are taken. There is little you can do in the field for iron poisoning other than provide basic attention to the ABCs and transport the patient to the closest, most appropriate facility. Miscellaneous substances. Chlorine gas. Exposure is relatively common because of the widespread use of chlorine compounds in the home and occupational settings. Cases of chlorine gas exposure occur both inside from mixing bleach and other cleaning products and outside the home. Signs and symptoms of chlorine gas exposure are burning sensation in the eyes, nose, and throat, slight cough. With more intense exposure, you will have chest tightness, choking, paroxysmal cough, headache, nausea and vomiting, diffuse wheezing, cyanosis, crackles in the chest, shock, seizures, loss of consciousness. Remove patients from the area of exposure. Once you are in a safe environment, quickly triage the patients, prioritizing patients with breathing problems. Irrigate burning or itching eyes with water, as well as any areas of the skin that have come in contact with the chlorine. Cyanide. Exposure can occur as a result of a combustion in a fire, industrial exposure, after ingestion of products that contain cyanide. Cyanide exposure blocks the utilization of oxygen at the cellular level. It can occur within seconds if the cyanide was inhaled, within minutes to 2 hours if cyanide was ingested. A patient who has been poisoned with cyanide may have an altered mental state. The patient, if awake enough to answer questions, may complain of headaches, palpitations, or dyspnea. The classic odor of bitter almonds on the patient's breath is highly suggestive of cyanide poisoning. Respirations are usually rapid and labored early on. As the poisoning progresses, they become slow and gasping. The pulse is usually rapid and throaty. Vomiting, seizures, and coma are common. Treatment must be instituted as fast as possible. Administer 100% oxygen via non-rebreathing mask or positive pressure ventilations. In the pre-hospital setting, amyl nitrate may be used. If given in time, it is usually effective. Call for paramedic backup and a commercially available cyanide antidote kit. These are manufactured by Eli Lilly, if available. Notify the receiving hospital of the probable diagnosis so that staff can make preparations. Transport the patient without delay to the appropriate facility. Caustics. These include strong acids and strong alkalis. Both types of chemicals are commonly used in the industry, agriculture, anhydrous ammonia, and the home, such as in bleach. Most cases of exposure to caustics involve accidental dermal or ocular exposure. If the patient is an adult, oral ingestion of caustics is usually an intentional suicide attempt. Signs and symptoms of caustic exposure is most patients who have swallowed caustics have severe pain in the mouth, throat, or chest. Usually the airway is not a problem. Patient is usually not in shock. Respiratory distress, if present, is most likely due to soft tissue swelling in the larynx, epiglottis, or vocal cords. If so, the patient is in immediate danger of complete airway obstruction. Establish IV access, usually en route because immediate transport to the ER is needed. If the patient was exposed to a strong alkali, diluting and flushing away the caustic substance is the main goal. For an eye exposure, continuously irrigate. If only one eye was exposed, be sure you do not contaminate the other eye while washing. Methyl alcohol and ethylene glycol, even more toxic than ethyl alcohol, which is drinking alcohol. Methyl alcohol is found in dry gas products and sterno. Ethylene glycol is found in some antifreeze products. Both cause a drunken feeling. Left untreated, both will also cause severe tachypnea, blindness with methyl alcohol, renal failure with ethylene glycol, and eventually death. Even ethyl alcohol, which is the typical drinking alcohol, can stop a patient's breathing if taken too fast or in a dose that is too high, particularly in children. Although they may be used to a substitute by a chronic alcoholic who is unable to obtain ethyl alcohol, they are more often taken by someone attempting suicide. In either case, immediate transport to the ED is essential. Hydrocarbons. These are found in a variety of products around the home, including cleaning and polishing agents, glues, spot removers, lighter fluids, paints, paint thinners, paint removers, other fuels, and pesticides. The vast majority of intentional hydrocarbon inhalations are recreational. Hydrocarbons may also be ingested by young children who mistake them for a beverage. Inhalation is achieved by pouring the volatile material onto a rag, placing it in a trash bag, and holding the bag over the face to breathe in the fumes. Breathing fumes directly off a soaked rag or towel is termed huffing. The use of a trash bag is termed bagging. A single hydrocarbon substance exposure may cause life-threatening toxicity and on occasion sudden death. Treat a patient who has inhaled hydrocarbons by removing the patient from the noxious environment, giving high concentration supplemental oxygen, promptly transporting to the appropriate facility. Patients who have symptoms such as coughing, choking, or vomiting within a few minutes of ingestion are likely to have aspirated and need immediate attention. Signs of respiratory distress must be considered danger signals. This is air hunger, intercostal retractions, tachypnea, and cyanosis. Hypoglycemia and cardiac arrhythmias may occur. Call for paramedic backup if needed. The patient may have severe abdominal pain, diarrhea, and belching, sometimes lasting for hours after the incident. Management should include the following measures. Remove contaminated clothing and decontaminate the patient, ideally before placing the patient in the ambulance. Establish and maintain the airway and ensure adequate ventilation. Administer high-flow supplemental oxygen. Establish IV access. Administer sequential boluses of normal saline to treat hypotension, and transport the patient to the most appropriate facility. Food poisoning. You should think food poisoning with 2 or more people sick at the same time and the same scene if this is not a carbon monoxide poisoning. Almost half of food poisoning occur in restaurants, cafeterias, and delicatessens. 3 toxins produce roughly 35% of food-related deaths. Those are Salmonella, Listeria, and Toxoplasma. Poisoning with Clostridium botulinum is an extremely deadly toxin. It is usually the result of improper food storage or canning. Toxins produced by dinoflagellates in red tides may contaminate bivalve shellfish such as oysters, clams, and mussels and produce life-threatening or fatal paralytic shellfish poisoning. Cooking does not kill these toxins. Depending on the toxin, the onset of signs and symptoms may be several hours after ingestion or days or weeks later. The longer the time until symptom onset, the more difficult it will be to link the patient's problem to the event at which the toxin was ingested. GI complaints are the most common. They may include abdominal pain and cramping, nausea, vomiting, and diarrhea. With prolonged episodes of vomiting or diarrhea, hypotension secondary to fluid loss, and electrolyte imbalance become likely. Respiratory distress or arrest can occur with toxins such as C. botulinum or those found in paralytic shellfish poisoning. Management is usually supportive. Most cases will not be life-threatening, usually self-limiting. Establish airway, advanced as needed. Give high-flow oxygen. Establish vascular access. Administer fluid for hypotension secondary to fluid loss. Call for paramedic backup early as needed, and transport to an appropriate facility. Poisonous plants. Only a few plants are poisonous. However, poisonous plants represent some of the most common ornamental shrubs and houseplants. Most plant-related exposures involve children under the age of 6 years. Death from plant ingestions are rare. Table 23.5 in the text lists common toxic plants. Some poisonous plants cause local irritation of the skin. Others can affect the circulatory system, the GI tract, or the central nervous system. It is impossible to list them all, but 2 are worth mentioning. The Dieffenbachia is a green plant with broad, variegated leaves. It is nicknamed the dumb cane because eating this can result in a person being unable to speak. In severe cases, edema of the tongue and larynx may lead to airway compromise. Ingestion is common in children and cats. Castor bean seeds. They originate from an attractive shrub but are highly poisonous. Chewing on just a few seeds, and in some cases just one, can kill a child. Ricin is the poison that is in castor beans. It causes a variety of toxic effects: burning of the mouth and throat, nausea, vomiting, diarrhea, severe stomach pains, prostration, failing vision, and kidney failure, which is the usual cause of death. When you encounter a case of plant poisoning, get all the information you can from the plant and then consult your regional poison center for advice. When was the plant ingested? If it was more than 12 hours ago and the patient is still asymptomatic, chances are good that the patient will not experience symptoms. Most plant poisonings produce signs and symptoms of toxicity within 4 hours of ingestion. Castor beans are the exception. It may take 1 to 3 days for symptoms of castor bean poisoning to appear. Find out what exactly was eaten. Try to find out not just what type of plant, but also what parts of the plant, leaves, roots, stem, flower, or fruit, were eaten. If possible, estimate how much was ingested, such as a bite or two from a leaf, 3 or 4 leaves. If you transport the patient, take along the offending plant or whatever is left of it. Find out what signs or symptoms, if any, the patient has. Most plant-related exposures require no treatment. Check with poison control, medical control per local protocol before making decisions that no treatment is required. If there is a responsible adult who can keep a close eye on the child for at least 4 to 6 hours after the ingestion, there may be no need to transport the child to the hospital. A child with any signs and symptoms should be evaluated in the ED. Emergency medical treatment of the Dieffenbachia poisoning includes maintaining an open airway, administering oxygen, and transporting the patient promptly to the hospital for respiratory support. Continue to assess the airway for difficulties throughout the transport, and if necessary, provide positive pressure ventilation. The toxins in these common poisonous plants are often ingested or absorbed through the skin. The first one is the Dieffenbachia. B is mistletoe. C is the castor bean. D is nightshade. E is foxglove. F is rhododendron. G is Jimson weed. And H is death chemist. The toxins in these common poisonous plants are often ingested or absorbed through the skin. These are poison ivy, poison oak, pokeweed, rosary pea, and poison sumac. And that is going to be it for your toxicology, chapter 23. Test Monday and Tuesday is going to be chapters 21, 22, and 23. As always, if you have any questions, let us know.